One clinical dilemma that I've run into over the years is really differentiating chronic retinal vein occlusion from chronic retinal artery occlusion. And I'd like to demonstrate how OCTA has helped me with this dilemma. My name is Yasha. I'm an associate professor of ophthalmology at NYU. These are my financial disclosures, which are listed here. And when we think about the management of retinal vein occlusion, particularly in individuals over 50 years of age, these are frequently individuals where the goals of care are management of hypertension, hyperlipidemia, blood glucose, and glaucoma. When we think about the management of retinal arterial occlusion, these individuals with CRAO can have two major possible causes, one being embolic causes, and the other being an evaluation for giant cell arteritis. For branch retinal artery occlusions, these can be embolic causes, or there can be rare uveitic entities like lupus or Sussex that can contribute, but the workup is drastically different. In these cases, we look by doing carotid ultrasounds, cardiac echoes, because the management of a retinal artery occlusion, that's effectively a stroke until proven otherwise, and these can have drastic medical implications. But you may say, well, who would confuse these two? And when you look at this confused gentleman, I promise you, I have in fact confused retinal artery occlusions from retinal vein occlusions. And so when you look at the acute stages, this is a beautiful image from Dr. Major. We can see a very classic appearing sort of quadrant of retinal hemorrhages indicative of a branch retinal vein occlusion. And here we can see an acute retinal artery occlusion with ciliary retinal artery sparing. We can see the whitening of the retina with a cherry red spot. So this in itself is not a diagnostic dilemma. But what about this image? What's the diagnosis here? And what if I told you that this was 3 years after that first branch retinal vein occlusion? Notice the hemorrhages go away. There's sclerosis of the vessels in the superior temporal quadrant, and there's still some peripheral superior temporal hemorrhages, which could help you clue into the fact that this is in fact an old branch retinal vein occlusion. But the OCTA really shows the distribution of non-perfusion, and here we can see some areas of vascular remodeling, which we don't see in branch retinal artery occlusion, and we'll go over that in just a second. What's the diagnosis here? This is a patient with actually a subacute central retinal artery occlusion. This is at least a couple of weeks later. And what we see is there's maybe a little bit of whitening in the macula, but it's much, much harder to detect after the acute event. When we look at the OCT, we see inner retinal thinning, and that hyperreflective signal tells us that we're still in the subacute event. And eventually, all of that hyperreflectivity will go away as we move on to the more chronic stages. Here's another vertical raster of that same patient. And when you look at the FA, here we can see 23 seconds, there's absolutely no perfusion. 25 seconds, we're finally seeing arterial perfusion, so certainly delayed perfusion. But if you go out 41 seconds, it doesn't tell you where the deficit occurred, what part of the retina was ultimately affected. And if you look out at 6 minutes, it looks nearly perfectly normal, with maybe there's a slight exception of this one artery. Hard to tell, though, by fluorescein angiography in the setting of reperfused retinal artery occlusion. But what if you take a look at the OCTA? So here's the superficial capillary plexus of a 3x3 image. And what we see is that we've lost vascular density at the microvascular level. And this respects the RAF-A and confirms a superior branch retinal artery occlusion. Now take a look at this image. Which one is a retinal vein occlusion and which one is a retinal artery occlusion? Well, if we just look and say, hey, there's inner retinal thinning, that's going to be associated with some ischemic event, exactly as Caroline had so well pointed out in the prior talk. But it's really hard to know. Well, this top event, this is a branch retinal vein occlusion, and the bottom one is a retinal artery occlusion. So how do you use OCTA to differentiate between these entities? When you look at a BRVO, we can see that the classic hallmark feature of chronic BRVO, especially ischemic BRVO, is venous to venous anastomosis and vascular remodeling, which we can clearly see on the OCTA. Now, when you look at a artery occlusion, for whatever reason, there is no vascular sort of reanastomosis. And all we see is a loss of density of the capillaries at the superficial capillary plexus and more consistent at the deep capillary plexus. So when I tried to make that differentiating feature, using the deep capillary plexus sort of cube is really what's going to cue me into the fact that there was an arterial occlusion. Now, I want to show you two cases. This is a 55-year-old hypertensive woman who presented to me for a second opinion. The visual acuity is 2100. And she said, well, what's my diagnosis and why is my vision so poor? And so when you look at the horizontal slice, it looks remarkably good. And so actually, I was a bit perplexed when I saw her because it was really hard to reconcile why her vision was so poor based on the way the OCT looked. But if you move over to the inferior macula, this was the retinal vein occlusion patient that I had showed you earlier with severe intraretinal thinning. Now, take a look at depth encoded OCTA angiography, where you can see the sort of area of non-perfusion inferior temporally respecting the raphe. And if you zoom in a little bit, what you see is all of these large red vessels in the temporal macula. That's venous to venous anastomosis. So essentially, you have a connection from the superior unaffected retina all the way down to the inferior retina as a sort of compensatory response to the ischemic event from the branch retinal vein occlusion. Here's another patient, a 66-year-old woman, hypertension, PDR. She has coronary artery disease, but has not had a stent. She has peripheral neuropathy as well, and she's presenting to me for her first evaluation. Now, certainly I can see maybe perhaps here some IRMA, exactly as Dr. Major had pointed out. There's also some PRP that's not well visualized on this fundus photo, and she has extramacular diabetic macular edema or extrafoveal diabetic macular edema. And it's easy enough to go and say, hey, I'm going to chalk all of this up to diabetic retinopathy. If I look at the horizontal foveal slices, I can in fact see some areas of deep capillary plexus ischemia in the form of ripples. And what we can see in the left eye is perhaps there's some ellipsoid zone changes indicative of perhaps that she had some diabetic macular edema in the past with some associated atrophy. But take a look superiorly in the retina in the right eye. And what we see is uniform thinning of the inferior retina. Now, we talked about how you can get these focal areas of thinning in diabetic retinopathy, but this appearance is certainly not consistent with diabetic retinopathy alone. And when you look at the OCT angiography, what we see is very clear signs of loss of the superficial capillary plexus and the deep capillary plexus here. So this is a patient who has had a proliferative diabetic retinopathy event and has a chronic BRVO that was previously a BRAO that was previously undiagnosed. So at this point, I said, this is problematic. And of course, naturally, individuals with severe diabetic retinopathy are more prone to developing heart attack, more prone to developing stroke. And so I said, we need to check a carotid ultrasound, cardiac echo, hemoglobin A1C, lipid panels. I checked her blood pressure in clinic, which was elevated, and also a UA. Unfortunately, kind of what we see in a lot of our diabetic patients, this patient was lost to follow-up. She returns in a wheelchair with left hemiplegia after having a right CVA and MCA stroke. Her blood pressure, her lipids, and her blood glucose are now better controlled, and she's on aspirin and Plavix after undergoing endovascular stenting of her carotid. Now, arguably, we may not have been able to prevent this from occurring, but if we had concluded this workup, we would be able to identify perhaps that she needed endovascular stenting prior to her CVA. So identifying these differentiating features can have really significant clinical import. In the acute stage, this is obviously quite easy, but this gets much harder in the chronic stages. So look for venous remodeling, specifically crossing the raphe to identify retinal vein occlusion, and look for loss of capillary flow in the DCP for retinal artery occlusion. Retinal artery occlusion, even if chronic, should be evaluated as a stroke, and intensive medical investigation and stroke parameter control of labs should be obtained.